Dr. Ioannidis, when we spoke to you on March 23rd, you said we needed more data before we could ascertain what was happening. Since then, you've been busily gathering that data and have published 3 studies. Let's start with the latest one, which you entitle COVID-19 Antibody Seroprevalence in Santa Clara County, California. What was the purpose of that study, and what did you discover?
This study aimed to generate an estimate of how many people in Santa Clara County have been infected with the virus. And the way to find out is to try to see whether they have developed antibodies to SARS-CoV-2. So we had a sample of residents in Santa Clara County evaluated for the presence of antibodies. And the sample was 3,300 people who came to be tested. We estimated that based on what we saw, between 2.5 and 4.2% of the population of the county has antibodies, which is an indication that they have been infected with the virus a while ago.
What are your conclusions based on your study?
If you compare the numbers that we estimate to have been infected, which vary from 48,000 to 81,000, versus the number of documented cases that would correspond to the same time horizon around April 1st, when we had 956 cases documented in Santa Clara County, we realized that the number of infected people is somewhere between 50 and 85 times more compared to what we thought, compared to what had been documented. Immediately, that means that the infection fatality rate, the chance of dying, the probability of dying if you are infected, diminishes by 50 to 85-fold, because the denominator in the calculation becomes 50 to 85-fold bigger. Our data suggests that COVID-19 has an infection fatality rate that is in the same ballpark as seasonal influenza. It suggests that even though this is a very serious problem, we should not fear. It suggests that we have solid ground to have optimism about the possibility of eventually reopening our society and gaining back our lives.
Sooner rather than later, I hope.
Sooner rather than later, with full control and a data-driven approach.
Welcome back, America. We have a tremendous guest, Dr. John Ioannidis. Welcome. You are co-director of the Meta Research Innovation Center at Stanford University, the Reinborg Chair in Disease Prevention, Professor of Medicine, of Health Research and Policy, of Biomedical Data Science, and of Statistics. You're one of the most cited medical researchers ever. Professor of Statistics at Stanford University. You're a member of the U.S. National Academy of Medicine. And in research that you conducted, and 2 others posted on April 8th, you concluded that, quote, based on the data until April 4 for the whole COVID-19 fatality season to date, the risk of dying from the coronavirus for a person 65 years old is equivalent to the risk of dying driving a distance of 9 to 415 miles by car per day. Now, I have been saying, and then I look at your research, that the numbers that were thrown around early on, models that were not really made available, data which I didn't comprehend, and maybe it's because it wasn't very solid, these huge numbers of millions of Americans were going to die, then hundreds of thousands of Americans were going to die. I could never find the real basis for these numbers, and the media kept pushing them, and they had charts on their monitors and on their screens every day. Then I read your piece. It says, wait a minute, we don't have reliable data. Tell me what was in your mind when you wrote this piece, and tell me why you were right.
Thank you for the very kind invitation, Mark, and thank you for giving me an opportunity to try to answer these tough questions. I'm a person who's working with data, and I'm also trained in infectious diseases, so it was natural that when the COVID-19 pandemic evolved, it became a top priority for me to understand what was going on. And much like many other scientists, I started looking at what information do we have available and how solid is that evidence that is guiding decisions that have monumental impact on saving lives and also potentially harming lives because of the consequences of some of the measures. It became very obvious to me that the evidence that we had in the early phases of the pandemic was utterly unreliable. We had to base our decisions on whatever we had, and I think that we did the right thing to act decisively and urgently. However, many of the numbers that were circulating were based on how many patients we were seeing with symptoms who got tested, and then how many of those died. It was possible that there was just a tip of the iceberg, that many more people could have been infected, and actually they're never documented because they were never tested, so the denominator might have been much larger. The original figures that were circulating and the ones that were circulated by WHO suggested that 3.4% of those people who we diagnose, we give them a label of COVID-19, would die. And of course, this is astronomical risk of death. And early mathematical models built on these assumptions, or a little bit toned down assumptions, but still making astronomical predictions about tens of millions of people dying around the world, 50 million people, 2.5 million people in the US, which of course would be a catastrophe that we had never witnessed before. However, that's not true. It is completely off. It is just an astronomical error. And over the last several weeks, we have started accumulating data that show that indeed there is an iceberg, and we were just seeing the tip of the iceberg. There's far more people who are infected with this virus. The vast majority of them don't even realize that they have been infected. They are asymptomatic, they have no symptoms, or they have very mild symptoms that they would not even bother to do anything about. The best data that we have now suggests that it's not 1 out of 30 or 1 out of 100 people who get infected who will die. It's probably in the range of 1 in 1,000. And we also know that there are some types of people who are at much higher risk than others. Most of the population has minimal risk. It's in the range of dying while you're driving from home to work and back. However, very elderly individuals, people who have severe underlying diseases, in the hospital in particular, or in nursing homes, there are settings and people who are at very high risk. And these settings and these people we need to protect fiercely and do the best and save lives. However, the original expectation that we'd be seeing tens of millions of dying individuals, that's not happening.
Now, I'm not a mathematician. I'm a constitutional lawyer, and there's a big gap between the two. You say 1 in 1,000. You're saying well under 1%. Is that 1/10 of 1% of the population that actually has the virus will pass away as a result of the virus or in connection to the virus?
So this is also an open question, because for the data that we have a little bit more mature and detailed information, like Italy, that has already gone through the peak of their epidemic wave, we realize that 99% of people who die with this virus have other reasons as well to die. On average, they have close to 3 other reasons to die. On average, they're 80 years old with other comorbidities, as we say, and there's quite some debate on whether these people would have died anyhow, if not immediately, perhaps in a few days or a few weeks or a few months. In our country, we see a fairly similar picture. We see that people who are disadvantaged, poor people, creating even further inequality in the population through COVID-19 seem to be very hardly hit. We see that the age at death on average is a little bit lower compared to European countries, in the range of 73 or 74 years old. And we see again lots of comorbidities in people who die with COVID-19. It's very hard to say how many of these people would have died anyhow and how much is the direct contribution of the virus. These data are evolving, but if anything, they suggest that the burden of disease, as we call it, the number of person years lost, how many years of life are being lost, is much less than even what the number of deaths would suggest. This is not to minimize the problem. It is a serious problem, and we need to deal with it, and we need to protect these vulnerable individuals who are actually among those that our society probably has not helped in the past. So we need to do everything to protect them. But in the big picture, the risk is much, much, much lower compared to what we thought before.
I think you and a handful of other experts, Dr. Katz of Yale and so forth, and your team have developed a growing consensus, I think, among experts and certainly among the people. Take care of the vulnerable, but let the rest of us go free. That we have lives to live. We'll be careful. We can mitigate. We'll figure this out. But we have 22 million people now who are unemployed. 22 million. God knows what it's going to be next week and the week after that.